and then examination of the eye movement and muscles, and then inside the eyes. Eyes, ears, nose, throat. Eyes, ears, nose, throat. Say it over and over in your mind, eyes, ears, nose, throat. Then we check thyroid and lymph nodes in this area, and then we go to the heart and lungs in the back, and kidneys while we're in the back. Then we go to the front, finish out the heart, lay the patient down, breast, abdomen. Oh, finish the cranial nerves in the front while we're in the front. Breast, abdomen, and some just peripheral circulation, and in the pelvic for the male genital exam. And by the way, if you're partnering with a male in the room, and we have a few of you fellas, then you're doing the exam on a male. So the male breast exam I'm going to demonstrate on Sunday when we do the breast exams, and I'll demonstrate on one of the classmates just clothed how you go about a male. So if you don't pretend to do a breast exam of a female breast exam on a male classmate. So if it's a male, you do a male. If it's female, you do a female, and you just get the luck of the draw. So try to know who you might be matched up with, okay? All right, so we start with peripheral vision. The Snellen's been done in the hall, and your hands have to disappear before they can appear. So you can't, and you never walk between a patient's legs, ever. You always walk to the side of the legs. And your hands, you can't say, tell me when you see my fingers, and they never they were always there. So they have to disappear before they can appear. So you go superior, lateral, and inferior. She doesn't have glasses on. If she did, the glasses come off because you can't test peripheral vision when you've got things blocking your peripheral vision, right? So if you have to wear glasses, you leave yours on. So the hands have to disappear. You can't have it be palms coming forward because she can't see your wiggling fingers. You need fingers forward. So tell me when you look at me straight, and so you need to put the chin up. If she's looking up because I'm tall and she's shorter, like she was, you put the chin up a little bit because you're trying to test her peripheral vision if it's full or narrow, okay? So look at me and then tell me when you see my fingers wiggle. Perfect circle, and it was in the right degrees. It was 180 flat. What we don't want to see is a real narrow one. You can't test this correctly if you say, tell me when you see my fingers. Too fast. She's like, now, good, okay, next. Doesn't help you. So we've done peripheral vision, slowly, fingers forward. Now I'm going to check your eye muscles. Follow my finger. Some people like to use a pencil, some people like to use a pen light or whatever, but you got this really cool thing that never gets lost. It's right here. So, so have them follow my finger with your eyes, not your head, so keep your head still. You're going to make an H. You're going to go in the same plane the whole time. You're not moving in and out. You're going to stay in the same plane, and you're going to go to all of the extreme conjugate gazes. So pull way up high, and you're looking. You pause for a minute. You're waiting for the eye to bounce, which is nystagmus. And you go to the other extreme. You're pulling the muscle really hard. Wait a little bit, and then you come across, and you're looking for any lags. And then when you go to the extreme corners, you're looking for oscillation, which is nystagmus. And then when you come to the center, again, you're looking for lags. And then when you come in, about an inch and a half away, so you want to see the convergence. Don't touch the nose, it hurts. Okay? So I've tested peripheral vision, I've tested central vision with the Snellen, peripheral vision, and eye muscle movement. Now we're going to actually look inside the eye. Dim the light so the pupil can dilate. We're going to talk all about this when we get to each system. So I dim the lights, put my finger on the wheel so I can focus, gasket facing my forehead. I hold her either, some people like the forehead, some people like the cheek. I hold her with one hand, so because the lights are a little dim and you're closing one eye and you kind of wobbly, you don't want to hit her. So it gives you a proprioception, right? So one hand, one finger on the wheel. You come into the side and come right in. None of this come in from outside business. If you come in from outside, the light on still? No. From coming in from the outside, what you're doing when you're not here, pupil shrinking. Why are you shrinking your pupil? By the time you get there, it's closed. So if you come in from the side and move over, and then boom, you have a couple seconds before the keyhole closes. She doesn't want to smell my coffee breath, although I don't drink coffee, and I don't want to smell hers. So you're stable, finger on the wheel, coming in from the side. If you're in there longer than you can hold your breath, which is the other reason why you hold your breath, it gives you the signal that you've been in there too long and it's really hurting the patient's eye. So, breath breathing, no, for 2 reasons. Odor and pain for the patient. Right eye, left eye, left eye. You say, well, my right eye is really the strongest one, so I need to always use it. So I'll check her right eye with my right, and then I'll check her left eye with my right. We're kissing. No kissing. No kissing. No. Left to left, right to right. Never. I don't want to hear an excuse. If you're blind in one eye, then you will adapt and you'll use some weird little technique, and that's okay, and that'll be who you are as a human being. Okay? Come to the other side, never between the legs. Stabilize myself, left to left, finger on the wheel, come in from the side. Look straight ahead, you're looking, there you go. And then focus and then up and up. Okay, good. All right, now, just look straight ahead, I'm going to check your pupils. I'm looking for consensual closing, making sure one isn't big or doesn't close at all or whatever. And we've got some other questions to ask later if there's problems like that. Or thyroid. Or metabolic issues. The nystagmus, why do we see nystagmus? When do we see nystagmus? For fine oscillation of the eyes. What kind of things do we see nystagmus for? With drugs, yes, and thyroid. Metabolic issues. Okay, eyes, ears, nose, throat. One thing I want you to notice, I picked up this otoscope in my hand, and I'm holding it. I'm going to do her eyes, ears, nose, throat, and then I'm going to put it down. Do not pick it up. Check your eyes. Okay, now I'm going to check your vision. Okay, then you pick it up and look at your ears. Okay, now check your lymph nodes. Okay, you pick it up and look at your nose. Don't do that. Pick it up once, put it down once. So, eyes, ears, nose, throat. You did eyes. Now I've got my scope in my hand. I'm going to check your ears, okay? Tugging on the ears, because if they have an external ear infection, it hurts when you put this in and it'll jump. So you want to make sure that you're not going into unknown territory. So you tug, does this hurt? No. And you're going to go into the canal and look. Now, you pull up and back for an adult. Adults are tall. You pull down and back for peds. Kids are small. So, and that straightens the canal so you can see what you're looking to see. You're also supposed to have one finger on the head or the skull to stabilize. So if they did jump, you wouldn't be jamming the scope into their ear. So you kind of have a stabilization. Does this hurt? No? In? No. Okay. This goes in the trash. It doesn't go on the table. There's no trash on the table. It doesn't go at the top. It doesn't go here. It doesn't go on the patient's shoulder. It doesn't go anywhere. It goes in the trash. They're icky. Yours was fine. Okay. Don't make commentary about cerumen. Oh, your ears are really clean. Because if there's cerumen there, they think they're dirty. And they're not. Cerumen is normal. Unless it's an impaction. We'll talk about that in primary care. Okay. Eyes, ears, nose, throat. Eyes, ears, nose. If you just do that over and over in your head, you won't forget what order you're in. The way to check the nose, you tip the chin up a little bit. You tip the nose up a little bit. The tip, you have them hold their breath because if they breathe out in the scope, it fogs up your screen. You can't see them. So you're just going in, you look at the turbinates, mucous membranes, perforations, and foreign bodies. So lift and lights on, and we go in, and we look, hold your breath, and look. And we put this in the trash. I'm still holding on to it, I'm not putting it down. Eyes, ears, nose, throat. This is how you look at the mouth. You want to get all of the pieces. Don't forget the teeth. Don't forget the cheeks. Don't forget the tongue. Don't forget the floor of the mouth. Don't forget, everyone just goes in and looks at the tonsils. Open, say ah, and then go in. We're missing all of that. This is how you check the mouth. Show me your teeth. I'm checking the gingiva, checking the gums. I'm looking at the lips. If there's cracks, anything open for me. I'm checking the tongue, the walls, the buccal mucosa. Lift your tongue to the roof of the mouth for me. I'm checking the floor for oral cancer. Stick your tongue out for me. I'm looking for fasciculations and checking cranial nerves and any help of the tongue. And then put your tongue back in and just say, ah. No, okay, yawn for me. Better. Now you can see the pharynx and the tonsils and everything. Sometimes ah is good. Yawn works. If that doesn't work, just stick. You have to gag. Once you gag them, you can see everything you see. Don't just say, oh, well, probably okay. I couldn't see it. You have to see. So either yawn, I say ah first, yawn, and then the stick if you need to do it. Okay. Eyes, ears, nose, throat. Put it down. Don't pick it up. Okay. Now, we're in the front. We can finish a few things. We're going to finish The rest, we did a lot of cranial nerves here, didn't we? There was like 3 or 4 of them that operate the eye. We did quite a few with the mouth, but let's finish them up. So puff out your cheeks for me. Raise your eyebrows. Smile. Frown. Frown. She doesn't frown. That's good. You're good. You know how to frown. And so we're checking the cranial nerves. That really is looking at all the different, I call them clown faces, all the different muscles of the face is what you're checking, 7, right? And then turn your head against my hand. And you see how I went across? Don't say turn your head against my hand. The book shows it this way. Turn your head against my hand. Your hands are sweaty. They've got makeup. We don't want to deal with that. So back of the hand, turn. Back of the hand, turn. And you're less likely to be passing germs and picking up stuff off of her face, like makeup and things like that. So you don't wash your hands after anyway, but still. So checking that. And then the last one is lift against my hands. Good. So we checked our cranial nerves. Now we're going to do lymph nodes, okay? So everybody is going to know all 12 of the lymph nodes by the time we leave today. It's very easy. So 2 fingers on the upper ones, 3 fingers on the lower ones. Pre-auricular, the auricle is the ears, right? Pre-auricular, right in front of the tragus. Pre-auricular, post-auricular, right behind the mastoid, post-auricular, and then occipital at the point of the skull here, at the occiput. So pre-auricular, post-auricular, occipital. That's easy. You have 3 down now already, huh? Pretty good. Now we're going to move to the jaw. Tonsillar, your fingers hook under. Tonsillar, and you do a little back and forth. Submandibular, a little back and forth. And then you hold the head when you push on this one because you don't want to push someone's head back. So you always hold the head, and you get right underneath here, that little hollow spot underneath. Submental. Okay? And now here, there's a couple of words for this. Superficial chain, you use 3 fingers. And anterior part of the neck, up high, it's called the anterior cervical chain or the superficial. I like anterior cervical chain because the other one is posterior cervical chain. So the 3 in the front, you make a little circle. 3 in the back, you make a little circle. So I like anterior cervical chain, posterior cervical chain. Then when you go down a little bit farther, just above the clavicle in the front, there's a whole chain here, and that's called the deep cervical chain. And then you lift the shoulders, and you tuck your fingers underneath, lift, and that's supraclavicular. And then while I'm here, I'll lift right underneath. You see how the clavicle bone pops out? Supraclavicular, above the clavicle, and then underneath it is infraclavicular. These are lung cancer and breast cancer nodes, or a bad lung infection nodes. So I checked the lymph nodes. So I did everything in the front that I need to do. Now I'm going to go ahead into the back, because now I'm at the neck still, so that's thyroid. So 3 things in the back. You're in the front of the patient, we've done everything. You go to the back of the patient, you do 3 things. Back of the patient, we need to check their thyroid. You examine the thyroid from behind. While you were sitting down here, low, and looking up and talking to her, the light bouncing off the shadow, really enlarged thyroid, you would have seen a shadow. You've already made that preliminary assessment, because you were looking at her while you were asking her about her sex life. So basically, you're trying to get a sense of it. But right now, everything seems fine. So your examination of the actual thyroid is behind. You're looking for enlargement that wasn't obvious and nodularity. Now, the way to identify the thyroid is turn your head to the left. You see this nice a little more. There's sternocleidomastoid muscle sticking out. Right in the lower third of the neck, in front of that, the thyroid is tucked behind it. Turn the other way. Lower third of the neck, right behind, underneath there. You put my fingers there. Now look straight. Now my fingers are in the exact right spot on top of the thyroid, but part of it's still underneath that muscle. I rock it back and forth, and I know exactly where I am, and I have her swallow. And the reason I have her swallow is the thyroid moves when you swallow up and down. So if there was a mass there, it might move against your finger. You're not checking to see if the thyroid moves when they swallow. They all move when they swallow. So you don't chart thyroid moves when swallowing. That's not what you're looking for. Your fingers are here, so when she swallows, you might feel something rub against your finger like nodularity. Okay, but you get your fingers right up underneath there to get the wings of the thyroid. And then you just check the front. Make sure that there's no mass in the front. Most of the nodularity is in the wings. Back and forth and anterior sweep. Okay, so now I've checked her thyroid. Now I'm going to check her lungs. Would you cross your arms for me and just touch your shoulders? Great. I'm telling her to cross her arms. She's going to go like this. You tell her to touch her shoulders. She's got it right. And what she's doing here is she's pulling her scapula out of the way from me, so I'm really hearing her lungs better. I'm just going to put my stethoscope here so that you can, I'm going to have you turn toward me just because, so they can see a little bit better. And I'll be leaning, which you normally don't lean. So I put my stethoscope in the areas in the back of the lung that are not covered by the scapula because we pulled the scapula out of the way, that's all. I don't want you holding your stethoscope the cool way, like you see everybody else on TV or whatever. Okay, let me just feel you here and feel you here, you got your hands all over her. Keep your hands off of her. You don't need to put your hands on her. There's your stethoscope. Listen, okay? Keep your hands off of her, especially when you're doing anterior. You don't want your hands palming her, okay? So each lung is its own control. So you listen here, high up, and in a healthy, normal routine patient, 4 in the back, 2 in the front spine. And if a patient comes in with lung problems, you've got 12 places to listen to, right? So high up, in the middle, deep breath in and out quietly through your mouth for me. Breath in and out quietly through your mouth. And then the other lung here, so you go across. Again, thank you. And then we're gonna go down, because now we're gonna get a new set, across, in and out, and then across. You understand? And if she had a lung problem, we were gonna listen to the peripheral, we go way over here, and then we go way over here. So you go a zigzag across. You go check each one at this level, and then come down, check each one at that level, and then come down, so it's more of a droop, 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 okay? The book has all this. Okay, so we checked her lungs. You can relax your arms down, you turn back a little bit that way, actually maybe just halfway. Okay, because I couldn't reach you to do there we go. So, the last thing we're gonna do, yeah?
I'm sorry, just when you do the zigzag, is there a pathophysiological reason you do that, or is it just to stay organized?
No, there's a reason, and we talk about it when we get to that chapter. Okay, but you're using each lung as a control. So the next thing, the last thing from behind, thyroid, lungs, kidneys. We're behind thyroid, lungs, kidneys. So we're going to check her, and there's 2 ways of doing it. You can either just tap the kidneys or tuck underneath the costo, which is rib, vertebral, which is the center, angle, CVA. So the ribs are tucked underneath there. You tap once, or some people do twice. Or you can put your hand there, and because that spreads it out a little bit, and you tap your hand so it spreads out the vibration a little bit more. It depends on what you want to do, what you like, or directly on. I always hit directly on. Don't hit really hard. If they do have a pyelonephritis, it hurts really bad. So there's just no reason. Just check. Does that hurt? Does that hurt? No? Okay, good. Over. So I've done my 3 things from behind. Now I'm going to step back in front. The reason why I like to do the lungs 2 in the front and then do the rest of my stuff and then do the rest of the lungs in the front is it gives her a chance to catch her breath. You're going in and out, in and out, in and out, in and out. Now, okay, got the thyroid and kidneys to kind of give her lungs a rest, and now I'm going to listen to the last 2 places. And I have them turn ahead because I don't want to smell the breath. And especially if they're sick, I don't want to get any germs. So in and out quietly through your mouth, last 2 places, and then again. Now, some people will do, you don't have really deep breaths, do you? Some people will do above the clavicle, which is the apices of the lungs, the apex of the lungs. Others will just do the upper third, and I just do the upper third. Now we're going to check her, and actually I should have done it over the down. It should be here and here. Now we're going to check her heart. So I'm going to change halfway through. I listen to everything for high sounds with the diaphragm, and then the bell for deeper sounds. So we're going to talk about, from our chapter, very specific sites that we're going to listen to. Right sternal border, 2nd ICS. Left sternal border, 2nd ICS, intercostal space. 3rd intercostal space in the left sternal border. 4th intercostal space, left sternal border. And then would you do me a favor, just lift your breast a little up to the left, pull back. Yeah, and then we go up underneath here, and we get mid-clavicular line at the 5th ICS. That's our PMI, right? You know that. Okay, hold on for just a second, and then we do the same thing, walking it backwards. Do not just drop the gown. Just do what you got to do. If you like the gown in the front, that's fine. You can move it apart and do it. But patients won't really listen to you when you're holding your breast and you do it. Patients stop listening to you if their boobs are hanging out. They get all nervous and they're uncomfortable. They like it to be covered. 3rd, 2nd right sternal border. Okay. All right. And so then now I'm going to do the DTRs. Hopefully you're more alive than my previous patient. So we did the lungs, cardiac, and then deep kind of move up to before we lay down. So let's see here. Oh, yeah, a little bit. Okay. A little bit, not much. Maybe the table. Maybe it's me. Just relax your arm. There. Ooh, did you see that one? Same name. The table, okay? And we're gonna just check the mini ones. Let me go over here so that people can see better, sorry. There it goes. A little bit. Just gonna lift you. Oh. Lost the shoe. Normally your patient does not have a shoe. There you go. And then you just, don't help me. There, you should push down into your palm. And then don't help me relax, just let me lift it. There you go. There you go, that one felt like that. Okay, let's lay down. And you rest again. Keep your patient covered as much as you can. And you want to scooch up a little so you don't have to. There we go. All right. So do you rest exam at home? Oh, good, I'm so glad. She's lying, they all lie. So I said, oh, good, I'm so glad. Well, I'm going to teach you my technique, and then maybe you can combine it with your technique, which is really the only technique you can have, which is my technique, which I've never done it before, ever. Okay, well, good, I'm so glad. That's really good of you. So one of the things we're going to do is look at your entire breast tissue. It's a teardrop shape, all the way to the top of the shoulder, under the armpit area, all the way to the breastbone, all the way around the teardrop. That's all breast tissue. From the top of the nipple up, 75% of our cancers are found. So people think that this is their shoulder and this is the breast, and they don't check it, and they should. So we're going to do that. So I'm going to check underneath the lymph node area, and then using the flat pads of your fingers in little circles, pushing hard enough to fill your ribs, all the way around, all the way around, and then all the way around. And make sure that the circles don't get so big jumps, but each circle should touch each other. And then all the way down into the armpits, all the way down, and then you should be pushing hard enough now when we make the second circle in, hard enough to fill your ribs. You've got to push harder. All the way in, all the way around. And then in the center, it's hollow underneath. You've never seen anything, so you have to push on it to be sure you're not missing something, okay? Side to side, top to bottom. Good. So now I've done this one. I'm going to have you do this one. Put your other arm up. The reason why we have you put your arm up, bunch of that so it's comfortable. There we go. Is that it spreads the breast tissue against the ribs a little bit better. If you think of the ribs as your backhand, and this is the top hand examining the ribs, the breast tissue spreads out nicer and flatter so you feel something, okay? I grab her here because this is going to tell her where to go, and then I grab her here, tells her how hard to push. This is what I'm doing. And this is breast control that teaches the patient how to do it. A lot of countries are stopping teaching self-breast exam. I'll talk to you about that in the breast health lecture. Okay, so underneath the armpit, if you feel that little wing right there, pull your fingers. There you go. That's where lymph nodes hang out, if they're there. You didn't feel anything, did you? No. Okay, and then push hard enough. Fill your ribs. Fill your ribs. Good. All the way around. So I'm guiding her with the one hand and pushing down with the other. All the way around. And then what I try to do, about halfway through, okay, keep on going. Good. And I start kind of letting go. No. And I help her because she's a dodo. She just didn't do it. Thank you for that. And then all the way down. And then, okay, now keep pushing harder. Good. Oh, look at her. She learned. And then now you move in for a second circle. And again, pushing harder, good, pushing harder, excellent. And I try to see if she's going the right direction, and if she gets out of, I can help her, right? Good, oh, you're doing an excellent job. A little bit of circles, better circles, good, good. And then in the center, side to side, and top to bottom. Kind of just rock it, there you go, better. Good, do you feel anything? No? I'm gonna double check you. I'm gonna go here, all the way around, second time, and double check her. Every woman should have 3 breast exams. Right? 1 here, 2 there. Teach her how. Okay. So, oh yeah, sorry. So, check your tummy. Any, oh no, I can leave that down. Tender spots anywhere? Okay. So, first of all, I listen to renal artery stenosis and maybe aortic bruit, maybe, but depends on the age group. So I just listen, and then I listen on either side, which is about just above the umbilicus on either side. That's where the renal arteries are. Number one cause, renal artery stenosis, of young person's hypertension. It's the misdiagnosis. It's number 1, renal artery stenosis. As soon as they go in and fix the stenosis, they don't have hypertension. So you just want to listen for bruits. I don't listen to bowel sounds. Okay. So I'm going to just check anywhere there's tender spots. So I'm going to be pushing all the way around from the top. I do a S shape all the way over from the upper quadrants And then I slide to the umbilicus, superficially, all the way over. And then I slide to the lower quadrants, superficially. And now I'm gonna push a little harder to look for deep masses or deep pain. I'm pushing harder. And I would push harder here, but I'm not, just for a bladder issue probably. And here. And now I go to the umbilicus, up, pushing harder. And then I slide up. And now my hand's on her abdomen, so I don't take my hand off, and I tuck underneath, and I push up. And then I take a deep breath, and her liver gets pushed into my hand, blow it out, and I follow it underneath. I should tuck nicely into the costal margin. I don't take my hand off her abdomen, I slide over, I take the other hand off. So this hand was here, and then here, this hand stayed on her abdomen, and I push and take a deep breath, and then follow underneath. That's good. Okay, so I started here superficially, over, middle, over, down, over, and then deep, so it's a big S. And then left. Okay, I'm gonna just check your pulses and then we'll get you into pelvic position. And I'm looking at hair patterns, coloration. I'm trying to see if there's anything that would be a concern of asymmetry. I look at onychomycosis in the nails. That needs to be treated because that becomes an issue. So I'm just generally looking at her peripheral health. And then we help slide her down to the pelvis. So much. Okay. Now into the long rows.